So I think we'll get going. The pizza's probably 10 15 minutes away. So we'll get going and talk. So thanks very much, Sebastian, for coming along and offering us your benefit of your wisdom and quite a bit of experience now, paragliding specifically. So I think Seb's going to just kind of take us through the general basics. It's not a replica of a... Who's done a first aid course here? Actually, I've done one many years ago. So there's kind of about half. Yeah, so it's not a replica of a first aid course. It's trying to be more, I think, more paragliding specific, hands-on, covering the general stuff, and then how to approach it, and then talking through a couple of case studies that he's had his interest and questions along the way. So just if you've got anything you don't understand, or you want to hear more about, just sing out. It's a nice small group, so I think we can keep it pretty informal. Thank you.
Thank you, Simon. Thanks for showing up tonight. For those who don't know me yet, short introduction on my own. So I'm Sebastian, German, on a working holiday actually in New Zealand. Did my paragliding license 4 months ago now. Already 30 hours flight time on the record. Quite proud. I'm a trained nurse and worked the last couple of years as a anesthesia nurse and ICU nurse, as well an EMT and firefighter, doing the first aid lessons for my local fire department as well, for the volunteer firefighting department. Yeah, so after the first accident a couple of months ago, so it was end of July at Gandhi, where the speedway crashed. A couple of days later, the safety report of last season showed up. I came up with the idea and asked Simon if he would be happy to have a pet talk or club night about first aid. At the beginning, I want to talk about, in general, a little bit about first aid and what is important, and a little bit more about the facts, the problems we have in New Zealand, and then, after all, I'm going through the two, unfortunately, happened accidents 2 weeks ago, or actually on Monday. Yeah, any questions before? No, that's good. Food?
You pizza first.
Simon, what's your plan?
Oh yeah, let's grab some picture and sit back down.
You asked Simon like if he's any good with plan.
Just waiting for those two. Good, so a few more showed up. I think I will start again from the point. I'm introducing again my own. So Sebastian, German, on a working holiday visa in New Zealand. I did my paragliding license 4 months ago. 13 hours of flight time already. Worked before New Zealand as an anesthesia and ICU nurse. I'm an EMT as well, a volunteer firefighter, and training volunteer firefighters on first aid back home. Yeah, so I came up with the idea after the safety report was released, and this was like the first thing I was looking at after starting my research. So one good thing is there are not many reports in a safety report. Maybe the bad thing is not every incident is reported. So we have like 41 reports without any injury. That's quite good. And 29 reports with an injury. So injury is already a sprained ankle, for example. So around about every fifth, not every fifth, 50-50 of each incident comes with an injured pilot. Doesn't mean that it's like when you're approaching a pilot who dropped or stumbled, you have already an injured patient. When injured, the most injuries we can expect are limbs and spine injuries. Any idea why this might be the common thing?
It's what we impact.
Yeah, so always trying to protect ourselves when we're falling, and the feeling of falling releases us or makes us to put our arms in front of the head, and we're not able to drop 10, 50 meters down and not injuring our legs, for example. And the spine, we're not always flying with a nice foam protector like students are doing, so the spine is super vulnerable. What would you expect is the most reason for an incident or accident? Which situation of flying?
Take off and landing.
So actually the landing is the most problem. 19 reports, so it's not just the incident, not just the accidents with injured patients. It's all about, so 19 flights of those 70 incident reports were during landing, 16 during gliding, and 8 just during launch. So our landing is the most important thing to look at. When we're approaching a patient, we're following a nice doctor's ABC. Anyone who heard about that before? A bit? So the doctor's ABC is what you're teaching first aid in general or for the public. Who knows the D? Yeah. Caleb, welcome. Take pizza, sit down, enjoy. What dangers can we expect when we are approaching a patient?
If they're hung up on a power line, it could be a current.
Yeah.
Cliff edges.
As well, yeah, that's good. Any slopes, any cliffs? For example, at Taylor's, what is there as well?
Road, traffic.
Yeah, other vehicles, other traffic. And another thing, water. So if the patient crashed down into the sea, I think it's not the best idea to follow, because we're not able to swim, secure a patient or a pilot who's drowning with a heavy wing. So it's not a good idea to follow sometimes the patient to help him. Otherwise we get in big trouble and have suddenly 2 patients. Other scenario is flying all the way up in the mountains, nice and white, not cocaine, it's snow, and especially avalanches. So be careful when you're approaching a drop pilot and look for your own safety before you do anything else. It's not helpful to have 2 patients at the same time, especially not when you're on a countryside and it takes a while to have EMS at the scene. The S is send help. Why I'm changing this is the thing, R is response, so I'm checking the response, but usually we are not able to approach the patient right forward. So I would request send help before you're approaching the patient. Maybe reception of your mobile phone is not that good that you're able to call for EMS and the helicopter when you're at the patient's side. So if you're able to call for help already before, do it before you're getting to the patient.
So you do that if you see them immobile?
If you witness the incident and you can expect an injured patient, I would recommend to do it before, especially when you're in the countryside, or use your InReach, for example, anything to get help, because it's really hard to care for a patient and send help when you're alone, for example. Yeah.
We've been told if you're going to trigger your InReach or PLB, you need to do it in a stationary location. So don't move after you've set it off.
That's true.
So if you're going to use a satellite
device, transmitting your position, of course. Yeah.
Make sure that you're in a position where you can then help, or you're close enough.
Yeah.
To help.
or where it's obviously that you're right next to it. So if you're releasing or triggering the inReach SOS in an open field and then going into a forest, for example, because the pilot crashed into a tree, you're not obviously at the scene anymore. Yeah, so make a clever decision. If it's useful to release the help already before, especially keep in mind when you're flying cross country, it takes a while to send a helicopter. So it's not like flying at Taylor's and 10 minutes later on the first response unit with the fire brigade is around, for example. When you're calling for EMS, I think that's quite obvious. You can call 111, but there's as well our other nice safety number. Is everyone
0508 accident.
aware of this? Keep it in your phone. When you have phone reception, use it. Do you want me to write it down again?
Yes.
Or
Easy.
five.
0508.
So then, right. Just to be sure, I'm not telling you something wrong. Has anyone heard about what 3 words?
Yeah.
Is it a common thing actually in New Zealand?
Fall from height. Those 3 words?
No. What 3? What 3 words is a application? Yeah.
Coordinates.
Because sometimes it's easier to transmit 3 words instead of multiple numbers,
Yeah.
and this might be a help. I don't know if you're calling 111 and telling them 3 words if they're.
When we checked with the Westpac helicopter operators last year or 2 years ago, they didn't know what it is.
Okay.
Yeah, I understood. I asked someone who was involved in the 111 system in the air, and I was surprised they said they didn't use it.
Okay.
So yeah, don't rely on that.
Yeah.
Better with some coordinates or something else.
Hey, Bess, can you change those letters to numbers? Because I've got a search and rescue number here that's supposed to be we use, and it doesn't seem to link up with yours.
222433.
Yeah.
Yeah. Sorry. Huh?
Letters to numbers.
Okay.
The last couple of letters are
433.
not required.
It is the same.
The last couple of letters are
222.
Ah, yeah. Sorry.
222433.
Yeah.
Yeah.
You don't need it.
So you don't need the N and the T, but
Yeah.
it's not going to do anything.
Yeah.
It's just easier to remember than
It's-
exide, right?
Does everyone know why we use that number instead of 111 though?
Goes to the Rescue Coordination Centre.
It goes straight through to them. You're gonna get a different budget for your rescue. So instead of St. John trying to send you a Humboldt first, or maybe even a bunch of cops just to check it out, the helicopters come in, you're getting the same response as you would get from a BLB, with the advantage of giving them extra information and obviously hearing back from them and getting advice on how to treat the patient and so on and so on. And also 111, if you call 111, you're also going to get help as well, but their radios and communication channels are being scanned and intercepted by journalists. And that's why 20 minutes after a crash at Taylor's, you will see an article in the news. If you go through the accident numbers, you will not get that. So out of respect to your mates and their families, if nothing else, it's a good number to have saved as well.
Good. Thank you.
Should also speed up the process quite significantly if helicopters need it, if ambulance can't get to the scene,
Yeah.
if it's in remote location or something.
They
Are
have
they
winches.
tracking your phone number these days or not?
No.
They're still not.
Who's
You
tracking?
You can tell them
Yeah,
to, but they don't do it. They don't do it
The helicopters
by
don't do it.
default.
Mm.
Definitely not the helicopter.
It's only on
the
the-
ambulance.
The helicopter is not equipped by it.
111 they can.
It's
They
only
can
on
actually-
request and on response. So if there's no response, if you drop off the line, they will coordinate to your phone. And if there's nothing to expect, they'll go based off your previous coordinates. So if you drop out of coverage and any form of signal loss, they'll track to your last coordinates. So touching on that last point, if you're using a mobile phone to trigger a warning, they'll go to your last known coordinates.
Oh.
So leaving a directional arrow of any form in an emergency response situation, the direction that you are is quite important. It's kind of basically data of heli store. If you have a crash and you've got no reception, you go pull it to where you can get reception, and you put some form of directional arrow, clothing, a pair of pants, whatever you can do to make an arrow in the direction of where you actually are, even if it's 10 metres away. That's the first thing you should do.
That's good.
Because they might not be able to locate you even if they have got access to that information.
Mm-hmm. Thank you. Yeah. So help is hopefully on the way. The R of Doctors ABC comes with a nice second abbreviation, AFPU. Anyone with AFPU familiar? No, that's good. Something new for you. When we're checking the response of a patient, we're going through alert or aware. So I'm approaching the pilot and saying, hey, you had an accident, are you okay? And he's responding, yes, I'm fine. His awareness is obviously there. Sorry, step too far. So he's obviously awake and responds to you automatically. He is in a good situation as well with V for verbal. He's answering on your question. That's mix up, sorry. So yeah, F, A and Y are super good. P is pain, so I'm approaching the patient. He's not responding to my question. What can I do? Hello. Huh?
Yes, sir.
Where's the collarbone?
Yeah, that's a good spot. Or
Pinch?
yeah, pinch anywhere where he's or she is experiencing a pain situation. So don't use a knife, for example, and cut the skin. Use anything unharming but pain releasing. So I'm checking, is he or she responding on the pain? If yes, that's already good. If not, unfortunately, the chance that he is unconscious or she is quite high. Yeah. So we're checking next on the breathing, which comes with an A before. So we're checking, is there anything obstructing? Of course, there might be nothing obstructing the airway of a pilot who flew before in the air, right? But we have a problem. There's a big muscle in our mouth, the tongue. And being unconscious, this tongue drops down and is obstructing your airway. So check if the tongue is obstructing his airway or her airway, and checking for breathing. Anyone familiar with checking on breathing? Yeah? What would you do?
Put your face next to the mouth and feel, and if you're doing that, you can look down their body and see if their chest is moving.
Mm-hmm. So, anyone happy to join me here in front and play an unconscious pilot?
Sure, Simon. He's not that far off anyway.
Stick that slug gun, man.
Oops.
Oh, come on, man.
Yay!
Thank you, James. So,
Facing up or down? Do you want me to crash?
yeah, so we're usually not.
How did you land when you?
So, we're always turning the patient on her back. Yeah, don't lose those. No. So, you're not awake. You're not reacting on my questions. You're not reacting to my pain, for example, twisting up at the collarbone. And then I'm checking for breathing. But the thing is, before I'm checking the actual breathing, as I'm opening the mouth, okay, looks good. We're not expecting that he vomit or anything else during paragliding, right?
So why do you check the airway before the breathing?
Because obstructed airway leads obviously to no breathing.
But why do you not just check whether they're breathing first and then check the airway?
It takes time. You don't want to lose time on checking the vitals.
Then you still could have obstructions that fall back into the mouth of the patient.
And to make it easier to listen to the breathing, hopefully, we're turning the back open, so you're going under the chin and lift this a little bit. This moves up the tongue where it sticks to the mouth, actually, yes, and makes it possible to make air flowing. So, actually, that's easier like this. So, ear over mouth, you can feel and hear floating air, and then you're taking a look at the chest as well. So you have three possible points to spot.
So we're
how often are we breathing per minute? That's good, thank you. Huh?
Depends how fit you are.
So 8 or 10 breaths? Make it 12 to 15 and I'm happy. So we want to have a patient minimum breathing 12 to 15, but we're not in a situation where everything is nice and easy and we're counting, okay. Takes a minute, right? So we're checking for 10 seconds. If there's no breathe during the 10 seconds, this is not a good situation for a patient, because more than every 10 seconds is less than 6 already per minute, and we need quite a lot of air to survive and to supply the brain with oxygen. So if you're checking the breathing, check for 10 seconds. If not, we have actually the worst situation you can expect, CPR. That's coding. I'm not introducing to CPR, unfortunately, because it takes a little bit of time to practice and to get it on point. If you want to get right down into CPR, do a first aid course on your own, because it takes alone 2 hours to talk about proper CPR, how to do it, how to train it, and yeah. Anyone with a CPR in real life before, so not experienced, performed? 1, 2, 3. Hard?
Yeah. We had a team of 2 doing it for 18 hours, and it was absolutely shattering.
Yeah. So already after 3 minutes, it's like, oh no, please stop. It takes so much energy for you to perform it, and yeah. If you are more than 2, that's already good. If you're just 2, that's quite hard. So yeah, we're not performing, we're checking for breathing. If the patient is breathing, that's quite good already. So we're not doing CPR. a patient who's, yeah?
One question on CPR. What are currently what's the ratio of compressions to breath?
You're pressing 30 times and breathing is 2 times.
Okay.
So doesn't matter if it's a kid, a newborn, or an old person. Stick to the 30 to 2 and you're happy to go.
30
Yeah.
to 2 no matter who, is it?
Huh?
30 to 2 no matter who.
Every patient. So for a general first aid, don't think about, oh, it might be different. In professional CPR and coding, there's a difference, but when you're doing it as a first aid, don't hesitate and do your 30 to 2. Yeah. A patient who is breathing quite good but is unconscious goes into hopefully not recovery position, because a patient who's, so I checked James on his back, laying on his back, but then after I received a nice deep breath, that's nice. I would turn him on his side in a recovery position. Everyone familiar with that? Hopefully. Nope.
If they've had a paragliding crash and they're likely to have a spinal, so if they're breathing, would you still
I'm
have
getting
a
to
recovery
this
position?
point, but I can talk about this right now. What is more dangerous? Dying from being not able to breathe properly, or sitting in a wheelchair for the rest of the life?
No, airway for sure. I guess I'm thinking like if they're not vomiting or.
Yeah, so in case there's a spinal trauma, don't care about that, turn him on the side or she, and prevent dying from vomit.
But that's only if they're not responsive, right?
Yeah. So when he is responsive, he's able to breathe and keep him on the back. Yeah. So C is circulation. This is more like I'm caring about more vitals if the heart is doing the good stuff, and C is as well as CPR. So in case we have no breathing, C is your CPR.
So if they're responding and they're breathing, well, obviously they're breathing and responding, you just leave them as they are, or you have them on the back?
They're breathing and responding, you leave them on the back.
Or as they land? Or
Yeah, so if you have a patient or pilot who crashed, obviously from altitude, I would say more than 2 meters. So there are standards, worldwide standards, and they changed it a little bit. What is an actual high altitude or high height trauma? They changed it a little bit. And the thing is, if the patient is able to walk or is getting up again before you're arriving, you can expect that there's a low chance to have a spinal trauma. So if you want to stand on a good side, leave him on the ground and stabilize the head. And don't move him. If you're happy with that and the patient is at the full time till the EMS is arriving, he's all the time conscious, that's not a problem. But in case he's losing his consciousness, bring him on the side, of course. So as long as he's awake, leave him on the back. When the patient is getting unconscious, turn him on the side. That's the higher risk to stop breathing by respirating vomit. Yeah. Let's take a look. Notes.
So in that situation, if someone's unconscious but you're right there with them and you can monitor them full time knowing that help is on the way, would you not leave them in the position that you found them in? They're unconscious but they're breathing, they're fine, there's no bleeding.
Unconscious, they're
You're in a position
there
to monitor them rather than shift them and risk a spinal injury. Could you not just stay there and monitor them until...
Not really, because in this situation, he or she is vomiting. you have no chance to get everything of the liquid and the thicker stuff out of the mouth. That's a high risk. Even if you're standing all the time next to him or her, it's quite hard. So it's not like, okay, I know he's vomiting now, I'm turn the head to the side and let it flow. No, that's like not possible. Because it's quite fast when you're vomiting.
The recent first aid course I did through the club actually with the guys who focused a lot on trauma and trauma cases and what have you. He's a paramedic guy and what have you, and he was saying the actual most of their injury to spines are done in the accident. It's reasonably seldom that you do a lot of damage by moving them around afterwards, as long as you move them carefully. And particularly if you've got someone else, you can stabilise the head, keep it the same as the body as you roll them onto their side, support, put something underneath so the head's not sagging, and you can do that pretty safely, even with someone with a broken back. That's what he was saying. So he was saying you don't be that scared about moving someone if you need to. Obviously, only move them if you need to, but don't be too worried about it. And obviously the other thing is, with us being in the outback country and that, so we've got to worry about hypothermia. And that's something you might have to move someone for as well. You can't just leave them lying on the ground because you're worried about their spine. And they, disappear with hypothermia before the rescue guys get there. So, but that was interesting. I'd always thought, you've got to worry about the spinal injuries, but you're saying statistically, it's very, very seldom that it's that moving them. I don't know, is that your understanding as well?
Yeah. So hypothermia is actually a big problem, especially when they're bleeding, inside. I will get to this point as well later on. And if you're at a bad place to stay warm, keep him warm or bring him to a place where he's in a better wind protection, for example, because wind chill effect is a big problem. You're losing quite a lot of temperature, body temperature, in a very short time. So when the patient is awake, ask if the temperature is nice and smooth or is he freezing, because in a case of a bleeding, lower body temperature follows worse or bad clotting of the blood. So the blood or the vessel is not able to seal on the primary sealing, and then you have a bigger bleeding all along till treatment starts in hospital, for example, or EMS. Doesn't matter.
So one thing we have is paragliders, which are great insulation if you bundle somebody up in a bunch of paragliders.
It's already a good start to use your jacket, for example, and put it over the body too. It's not like I don't want to apply heat on the body. It's more like insulating the existing temperature of the body. That's already enough. But if you are in a windy place and it takes a while, you can move the body.
Person, not body.
Hopefully not body.
Sorry. That's a good point. Don't move the body. Person. Important stuff for us paragliders. We're hopefully wearing all the time helmets, especially those full integrating helmets with the chin protection. What would you do with an unconscious patient wearing those helmets?
Take it off.
Pardon?
Take it off.
Why?
Because you have to check the breathing.
That's the point, actually. And you can't bring a person in a recovery position without removing the helmet and open the mouth and checking and all this stuff. So a couple of years ago, the old science was like, oh, don't remove the helmet, it will make everything worse now. As you said already, the actual spinal injury happens during the crash and not because of you. And we're back on the point, even if it gets worse, maybe it's a last chance to save his life instead of not checking the breathing. So remove the helmet, use a jacket, a blanket maybe, and put it under the head. Fixate the head till EMS is arriving. Some EMS people are still using those collars, stiff necks, to stabilize it. Even this is getting this changes in the science because there are like things showing that using a stiff neck is not improving the outcome of a patient. Some research worldwide showing, especially there was a big study doing a big research in Australia, I think, and they figured out that it made everything worse. So,
well, especially if they can hold their head themselves, right?
Especially for patients who are in a good situation, and it's not like so a patient who's awake and is breathing, and to prevent more damage, it's a nonsense to put on. Inline stabilization is good enough to prevent any other harm.
Sorry, Seb, just on the removing gear note, kind of talked about sea and snow and avalanches, but one of the dangers that is still there is sometimes the wing itself.
Of course.
So I'd just like to add it in there that especially if there's more of you and if you're by yourself, especially disengage the wing from the harness because that can cause a lot more trouble as well, especially if we're then talking about, a bad spot for an accident to happen.
That was the next problem, wasn't it?
Nick?
Nathan?
Yeah.
Right, yeah, sorry. Yeah, but we've seen it at Taylor's. We want to take care of the person, and there's first 3 people who arrive go for the person and check how they're doing, but then the wing is still semi-inflated and it's dragging them even further, so keep that in mind.
So I said the one about the helmet, was that like if you can check their breathing with the helmet on, you just leave it? Or
No, in general, you're moving it in general. It was just highlighting.
No, if it's open helmet, you leave it on.
If it's open helmet.
No, in general, you remove the helmet because the helmet is changing the position of your head, and you can't hold it in a proper position to check the breathing of an unconscious patient, of course. But even with a conscious patient, I would remove it because it makes everything easier to stabilize it, the head. And in case the patient gets unconscious, I already have removed it. So it saves a little bit of time again to bring in a proper recovery position. And I just wanted to point out the full face helmet is a bigger problem, especially because the movement is even worse with a helmet like this. Any other questions before I'm heading on? Yep.
Sorry, we talked about disengaging the wing from the harness, but would you also unbuckle them from the harness, or would you assess the situation first before?
So, no. As long as for example, talking already about the situation on Monday about those student harness with the foam protectors, for example, they are massive and it's really hard, especially on a slope, to turn them. If the patient is unconscious, I would definitely remove the harness to make it easier for me to turn the patient. Otherwise, yeah.
If they're conscious, they'll generally want it off anyway, at least unclip. So talk to them.
Yeah, make it easier without the pressure on the chest, for example. Always in the situation, and there's not like, this is the best idea. Talk to the patient. He will let you know what's wrong. Next spot I want to talk about is internal bleedings, because the external bleeding itself is bad, yeah, but the benefit is we can spot them easy. So, yeah.
I was just going to say that's another reason to take people out of harnesses,
Yeah.
especially a pod, is for
Pod, definitely, yeah. I didn't thought about that. That's a good spot, actually, yeah. We're checking in this special situation of paragliding for, first of all, for external bleedings as well. We don't have any safety gloves, for example, to check. So you just use your normal gloves and swipe around the body, see if there's any blood. Check the full body, and then you can see usually that there's blood on your gloves, because it's a safety for you to wear gloves and don't get in touch with any other blood. And yeah, but I think that's an easy thing to figure out.
Would you go, so a crash at Taylor is when no blood is necessarily obvious right away, would you still go for your gloves first thing?
I always had them on, so I didn't thought about that, but yeah.
No, I mean, like, would you go, I wouldn't go to a patient with mittens on, right? I'll put them on. But then I'll carry, if I'm going there, I'll carry my first aid kit that has the gloves.
Yeah.
So do I pull them up?
Yeah, protect yourself. So you never know if you have any little cut on your fingers and if you get in contact with infectious blood or even vomit.
Is blood really that bad these days? You come across the
It depends who you blood
You're in a
across.
situation, the person is bleeding out, oh shit, I haven't got gloves, I can't touch it. We've got to look at this responsibly.
That's your call, because I mean, I've got a friend who's a professional paramedic, and he would just let you die if he didn't have his gloves, basically, because he's not going to risk himself getting. But then he's dealing with lots and lots of people, so the odds if he was prepared to do that with too many people. But for us, it's a one-off.
Yeah.
You make that call, I'd get in there.
Well,
With my bare hands, but I take the risk. There's a small chance I could get, hepatitis or something, but
yeah, well, what's the
most paragliding pilots are pretty outstanding, healthy types of people.
So it's my personal thing, especially after 9 years working with, as you said, different types of people. Human liquid in any kind of, it's not fun. So I would protect myself, first of all, yeah.
So the risk factor is quite high that you could catch something from another person just through the blood.
It's existing, so yeah, if I can prevent transferring or any other. So it's your decision. If you're like, okay, I don't care, it's fine to touch blood. You can go for that.
You're likely to have some cloth or close fit clothing that you can just put on your hand, right?
If you have a spare shirt in your harness, for example, or something, use this.
So that does something that would soak the blood in actually help me?
So you need something where it's obvious to see blood. Doesn't matter if it's soaking, when it's like...
I think it's sort of protection for you.
No, I'm like, sure, plastic gloves will stop the blood from getting to me, but a t-shirt won't.
No, it's just soaking it. Of course, it's not 100% protection, of course, but it's like a thing you can do to protect yourself a little bit. Yeah.
Sounds like it's kind of a choice. Like if we haven't got gloves in our first aid kits and our harness, then it's a choice about whether you're going to just get in there anyway. And if you're concerned about it, then get some gloves and put them in your first aid kit.
You guys are all paragliding pilots, you're risk takers for fun.
As opposed to just for nasty diseases.
Double protection.
I see versus risking your life to save someone else's. That's what I was.
Doesn't have quite the same narcissistic appeal.
But it's easy enough to just get some gloves now.
Yeah, it's
isn't it?
about less than 5% or something when I did my heli first aid course. It's less than 5% chance of cross-contamination or anything like that. So you're better to get in there if there's nothing else available. If it's just you, that person is 100% going to die if you just don't man up, you know. But if you have got other options, use other options.
Yeah.
And if you've got some gloves, put them on.
Exactly.
Yeah. Also, 5% is about the same
It's
percentage
1 out of
for
20,
a
right?
paragliding crash.
So
Sorry for that.
yeah, to stop external bleeding, the only when there is an external bleeding, it's usually an arterial bleeding, so high pressure bleeding. Everyone familiar with arterials and venous bleedings? So the difference is venous bleeding is low pressure, so it's not really splat. Huh?
It's not squirting in your face.
Yeah, straightforward, and arterial bleeding is like, you can see that when it's coming straightforward. So put pressure on the wound itself and a little bit, of course, in front of, so more narrow or in the direction of the central body. And yeah, put pressure on it, and if you have any first aid kit, use the dressing to prevent the bleeding. Anything else what we can use is, like, for example, the compression strap of our wing, to make it a little bit tighter. For example, there's a external bleeding at the lower arm. I can use the strap on the upper arm to stop the bleeding. How much pressure do I need for stopping a bleeding?
Enough to stop it.
That's the right answer. So we will know that we are on a good spot of pressure when the bleeding is stopping. So you never know, and it's quite a lot of pressure to stop the circulation of blood. So yeah, that's like the basic stuff. And keep it simple. So if there's any external bleeding, be clever how to fix that. If you are happy to rip your shirt and use it as a dressing, for example, because the paraglider crashed not into a super clean environment, right? We have everywhere soil and dirt, and it doesn't matter if you take your sweaty shirt as well for dressing. So you don't have to look clean for the patient because he is already in a dirty situation.
You're not going to die of infection in the first 24 hours.
In a good country with good health or enough healthcare to prevent infections, we have antibiotics, of course. Yeah. If it's happening anywhere else, far away from any hospital, I don't know. If it's even better to survive or to die. Yeah, it's the fact. So if you have bad healthcare far away, where it takes you ages to get there, it might be a better thing to die instead of suffering all the time. After all, internal bleedings, hemorrhage. I wanted to let you know what a big problem internal bleedings are. I'm quite proud of my drawings. Unhappy pilot who crashed and has an internal bleeding, has a big problem. His actual full body is a big problem. Can you imagine how much blood is even in the lower arm, or not in the lower arm itself? How much blood is it possible to store? Like when there is an internal bleeding in the lower arm, how much blood could you get there?
Liter.
What was it?
We're starting with a little bit of blood.
Half a liter.
It's getting better. Okay, I will let you know for the arm in total. So you have forearm, 400 and 800 in the upper arm. So you have already one, more than, so this is around about an 80 kilogram heavy person. So of course, kids less, maybe me more, hard to say, but yeah, so 800 and 400 already in one arm in total, 1.2 liter. That's not a good thing. We're moving on. Sorry. Oh, yeah. And that's per side, of course, yeah? So 3 liters in a full leg. How much blood is in the body and in a person? Of course, again, depending on the size of the person.
How much did you say?
5 to 6 is a good thing. So already 3 out of 5 in one leg, maybe on the other side as well. Then you're on a bad side of living.
Yeah, how much can you lose before you do?
So you first of all get unconscious because the biggest problem is being suffering loss of oxygen in your brain. Right. So you will not notice that you're dying. That's a good spot. And yeah, if you're losing 3 liters, you fucked up. So it's hard to say because
total blood volume.
Yeah, so the total blood volume is depending on the size of the body. So it's like if you're losing 50%, you can be 100% sure that you're dying. Not you're dying, but the other one is dying. Because the heart will try to work against the loss. So if you have a closed circulation and you're removing 50% of the volume, the heart tries to compensate the loss by rising the heartbeat, and will not be enough pressure to support the brain with oxygen. What did I miss? Yeah. Next problem, our chest. Abdomen, and where is it? Oopsie. So pelvis on its own 5 liters. Abdomen on its own 5 liters. So any internal bleeding at this spot is quite a big problem.
You're forgetting one male body part.
You're saying it to me.
So be aware that internal bleeding is our biggest problem in first aid, especially after a high altitude or high height accidents. What can we do? Is everyone familiar with this one? So in a situation when a patient is in a shock situation, is getting pale, you usually put him on the ground, raises the leg to improve the supply of blood in the central part of the person. But in this situation, you even make it worse because you're putting more blood in the direction of the heart. This leads to more pressure again in the system, and in the end, all the blood gets released in any one of those parts of the body. So keep him flat. Fingers crossed, stay positive. And now the thing is, we can't see it right at the beginning when there's something happening with an internal bleeding. In case the patient has a hemorrhage, shock, what are the symptoms we can spot on without any technology, just looking at the patient?
Cold and
Clammy, yeah.
Wait up.
But
Increased heart rate.
yeah, heart rate, so you can check in the pulse. Pale, sweaty, yeah.
Nausea?
Nausea as well, yeah, and even vomiting is like a beginning. So
breathing.
Aspiration rate is rising as well, yeah. So when you're checking for the pulse, you can feel as well that it's not quite pumpy. So it feels like a thin flow. It's not. You can feel that there is a less pressure. You're not checking just for the rate of the heart. You can feel that the pressure is quite low, which is like a result of being pale as well. Yeah.
Will you change? Will you see change of the color in the area of the internal bleeding?
Later on, you can see that, for example, you have internal bleeding at the abdomen. You could see not really like a hematome, but kind of. So you change the color of the skin, and everything gets quite hard. So when you're pressing down the skin, you can feel the resistance because the blood is pressing from the other side.
Yeah.
But
so how long are we looking at? 30 minutes, 20 minutes before you could actually notice anything like
yeah,
this?
so this takes a while. But especially when you're far away from EMS, it's like a problem that can show up. So that's the thing is we can't do much more than just checking for it.
So if you're like suspicious of that internal bleeding being in one of the limbs, could you use a tourniquet?
You just elevate it, right?
Sorry?
You just elevate it.
Yeah, so
it's in the leg, you lift up the leg.
The thing is, you don't know where the actual spot is of the rupture, for example, of the arteria. It could be up there. It could be down at the elbow, for example.
I mean, if it's like obvious that it's a broken femur or something, you can
That's
see.
the thing. Why is there injured arteria, for example? Might be a fractured bone as well. That's one of the points. Thank you for mentioning it. The reason why we have internal bleeding is any damage to a bone, for example, or just the strong impact, the hard impact is enough to rupture the arteria. So if you have an internal bleeding, there's a high risk as well that you have a fracture you can't see, for example, which has damaged the arteria. So if you have a humerus upper arm fracture, which has damaged the arteria, and you're using a tourniquet, it's not really working because the bone itself is damaged. It's moving. You don't have the actual pressure.
What's the word you keep using? Theoria?
Arteria.
Arteria.
Is it artery? So arteria is like
Yeah.
the Latin word. Sorry.
That's good. So we elevate or put a tourniquet on?
It's not enough to elevate it with the artery bleeding.
Yeah.
So it will continue.
You can check for it, but you can't do anything.
So it's best to keep them flat.
Yeah, keep them flat too.
I've got internal bleeding, keeps them flat.
I mean, why not use the tourniquet if you could prevent from the rest of the body from rest of the body to going into that area?
Again, please.
Why not to use the tourniquet to prevent it from getting it worse?
You need the bone on its own, like the counter pressure, and if you have a fracture through the bone, it's quite hard to use it.
What if the fracture's down there? Can you use it above the fracture, or do you?
Yeah, might be a thing. Yeah.
So
But if the thing is, do you have a tourniquet?
yes. That's what I'm asking. Yeah. Sorry.
Okay.
Would you consider carrying a ball sock?
What's that?
On your finger and it tells you the
Pulse ox. Oh yeah. What do you want to check?
Well, the heartbeat, heart rate, and the oxygen.
So you're not just especially talking about the internal bleeding. You just want to know if it's a good thing. Of course, yeah. Makes it easier to monitor it. Of course, yeah. Caleb?
So I was taught if you had a gross deformity, straighten it. So if you had an obvious, say, broken femur,
Yeah.
straighten it to take any pressure off an artery that was ruptured.
So guidelines saying put it back into place. But if you have a dislocated fracture, for example, but not all joints are good to replace them, or not replace them, sorry, to
realign.
The acronym that we got taught was OAT, or OATS, which is one at a time. So if you have got internal bleeding, you only move one limb at any one time, and you always do it with support. So if you move a limb and you've identified that there's bulging or just disdentation or anything, you only move it with support. You don't move it and leave it. You always do one at a time and work your way around in like a clockwise motion if you whatever side of the body you're on. One at a time with support. And if you've got a femur, you're probably not even supposed to move it.
No, the muscle is quite strong.
If you try to move it, you just risk completely. You'll be dead.
And especially when you have a open fracture, it's better to keep the bone there where it is because it gives you pressure on the tissue itself. So it's like you're stopping the bleeding from releasing. Sometimes it's good enough, or you have enough pressure just from the internal bleeding, so you have a little bit of pressure on the wound itself. But when you're removing it, then you have a channel where blood can go through again.
What would you do about a suspected broken pelvis? Would you just leave it?
Tell them not to bleed. No, that's like a thing, right?
Bladder, yeah.
If you suspect broken pelvis, apparently it's better if they can hold the pee, so the bladder holds resistance. It open before it crumbles. That's what we were told anyway.
Okay.
I don't know.
If you can. So the idea behind it is to have more obstruction inside the cavity, that the blood is not. Or what do you want to talk about the fracture, or do you want to talk about the internal bleeding?
The fracture of the pelvis, and if someone pees after the accident, it causes the collapse of the pelvis, which causes the shock, which causes potentially death of the person.
Basically saying it can just hold back internal bleeding, aren't you?
I think that's
related to that.
No, it's more like it's not internal bleeding related. It's more like that shock from pelvis collapsing would cause potentially would be that severe that
I
cause
think
death.
the explanation was that a full bladder may be enough to support the pelvis from folding like a.
Bladder is depending on your condition and your age is not really big, so it contains around about half a liter, and the pelvis can contain 5 liters. So
You'd be surprised after 8 hours of flying,
Especially, I'm just kind of trying to summarize this from my memory, like my perspective. If you've got an internal bleeding on a patient, you kind of basically what we're saying is there's not really a lot we can do except identify.
As long as there is no EMS. So
phone and yell more panicked rather than actually
hurry up.
Treat them for shock and keep them warm.
Yeah.
That's about it.
What about binding the pelvis?
That's one point I wanted to mention as well. So, as well with the, for example, the compression strap of your wing, you could put pressure on the pelvis itself. So you're going around the pelvis and using, so it's not on the height of a belt, for example, you're going a little bit deeper. So you have your hip, and then you're going down, what is it, like 10 centimeters, and there's another exposed bone part, and around this you're going with the strap and put as much pressure as you can do, and the strap is able to keep, and then you're putting pressure on the pelvis to stabilize it.
So it's at this height you go around like this, you mean? Yeah.
So you're checking for the hip, and then you're going down on the side, and then you have another exposed bone part.
Sorry, is that
against the belt height?
Against the belt.
How do you know what that is?
I've not heard about it on the radio.
So that was for a fractured hip or
For a fractured hip / pelvis, yeah. So to put pressure on it, this might stabilize it. It's a chance to do. So I wouldn't do this when EMS is around in 20 minutes, but in the case of backcountry flying, and you're realizing, okay, patient's getting into shock, and I haven't figured it out so far, and you can feel it that the hip is unstable. That's another point. You can check for an unstable hip, and you will feel that anything is like weird. So you're putting pressure on the hip, and you're checking for a stable hip, and if this is not stable, there's a fracture. There's no other reason why the hip is unstable.
Just finishing up on that note, the bleeding sort of things, would you do anything for a limb that was an obvious internal injury, like not a compound fracture, but a fracture, anything that you can see there's swelling or something? Would you still raise the limb in any situation?
No.
You just get over that?
You immobilize a fracture as good as possible. So EMS is using SEM splints. So there's a metal core inside and it's soft outside to stabilize the joints before and after the fracture. But you're not putting the arm or the limb in general in any position to remove pressure by blood pressure. Is that good?
What sort of height of fall would you expect you're going to get internal bleedings occurring? The only one I've come across is a friend of mine, fell 12 metres still on the cliffs up here.
So,
is that guaranteed that you're going to be probably...
No, depending on your protectors, first of all, and then the kind of underground, if you're falling in a soft, nice lawn,
so it's not quite variable,
maybe a little bit moist soil, then it's a bit better to compensate the impact. But if you're falling on a rock, for example, stones.
Well, syncrates will do a great deal in that equation.
As well, yeah. So usually we're not falling in full gravitation acceleration, right? So we have a little bit of less impact. A person who's falling from 10 meters without anything has a high chance even to die straightforward. But in case we are dropping with our wing 4/5 collapsed, there's still a little bit of brake, or enough brake to reduce the impact speed. So that would be the first round of talking in general. Any questions about general first? Not general, but without any example.
At the risk of putting you on the spot, what is in your first aid kit that you can?
During paragliding, actually nothing, because I don't have one here. That's the true answer. So,
okay. Follow-up question: would you agree that flying backcountry, if you don't back up your first aid kit with a New Zealand GPS communication device, carrying a first aid kit doesn't even matter?
I didn't get
So
it.
having
So-
a first aid kit,
Yeah.
you don't have BLD or
Yeah.
inReach, will actually not give you much help in
No.
that country, New Zealand. Correct? For a while.
Yeah.
For a while.
Yeah. So,
It can still help though. Something's better than nothing.
Yeah, if no one's coming.
yeah.
You know, if it's not so bad, okay, maybe they can limp out of it. If it's bad and no one's coming, whatever we discussed here,
Yeah, it's unnecessary. Yeah,
doesn't matter.
so it doesn't matter anymore
I mean,
because
if it's bad, you're not going to be able to use that first aid on
Yeah.
yourself anyway.
so what's inside a first aid kit in general? So I'm not talking about okay, you made some idea, you came up with this might be helpful as well, and put it extra on it, but you go to your next outdoor shop and buy this little cute red first aid kit. There's dressing stuff inside, there are gloves inside.
Saline. Little saline tubes.
Yeah.
That's
Not-
something still better than nothing. If you've got a couple of saline tubes, a couple of bandages, some form of tourniquet, I've picked up guys out in the middle of the bush who've just gone hunting and had a fall and, had a gash. And they've, covered up a gash and reduced the risk of infection from an injury. You might fall out of the sky, yes, but you might have a minor gash on a bush on the way
Yeah.
in and still be able to walk out. You're still better off with some saline, some bandages, some form of securing the wound. Even, if you've got some bandages, you can make a splint out of 2 bits of wood if you fall in the bush.
Yeah.
It's still better to have something than nothing if you're going backcountry, because you could be out there by yourself, away from your buddies. It could be a 3-day walk out.
Yeah.
This guy who came past the camp once with frostbite, and he'd basically tourniqueted off one of his toes that had gone black, like a lamb's tail, and he was still walking out, and one of the only things he had in his first aid kit was basically a piece of string, for whatever reason, and he had just gone, oh, that toe's gone black, it's dead, and to stop the risk of infection, he just tourniqueted off his own toe, and we had a truck on this camping trip, and put him in the truck, took him out, and he got home safe, lost his big toe because of it, but he still had a piece of string or whatever from somewhere. You'd be better off with something than nothing.
You'd also be better off having a PLV.
Yes.
I feel like an emergency blanket's probably the most valuable thing. Outside of PLB.
Exactly. But they don't always work, but sometimes PLBs just don't work. Even if you test them beforehand, they might fail over the course that you go on a duration of the flight, or you're again in a heli, you might crash and your transponder or something might not work in an aircraft, so you're still better off having that first aid kit there than not.
That's good. That's a good point. Yeah. Any other questions? Good. Overall, last but not least, I want to talk about the 2 accidents that happened the last 2 weeks. First of all, a speed wing. So far, the reason barrel roll and low height in front of the landing at Taylor's. And second, a student during lessons who had, as I can figure it out, kind of a B-stall, flat spin, 10 meters above launch or in front of the launch. So first accident 2 weeks ago, I didn't witness the accident on its own, got information by or from Brian and Bevan. And I offered to come down to the landing to support them. On my arrival, I approached a person who was in kind of a shock situation, was afraid that something was wrong with him. And in this case, actually, we kept the helmet on because it was a good support of the head during this time. He was awake, with pain, but awake. And then I did a short first assessment on the body, so I tried to figure out if there is any fracture. I didn't see any blood. According to the way of his accident, I decided not to turn him around, because if you would do a first assessment in total, you usually turn the patient around as well to check the back. But without any EMS, I wouldn't do this. So in this case, we had it's too late already. Neurodeficit, so he felt a little bit, the skin was numb a little bit, so this is already a sign for spinal trauma or spinal shock. So just the impact is already enough to have a swollen tissue around the spinal cord, and this pressure results in a kind of spinal trauma symptom. So definitely don't move the patient until everything is there which can help you.
Where did you check for that neurological deficit?
All around. Right. So I checked limbs and body, and he mentioned that the part of the abdomen is as well a little bit numb. So the sensory nerves of the spinal cord are attached to the spinal cord. Of course, it's on its own, but when there is like a weird feeling on the skin, that's already a sign that there is a nerval problem. Yeah.
So it's just going
Is that just like touch?
Yeah, I was going to ask. So you're going around and checking his body.
Yeah.
And you're
and
talking
he was
to him at the same time. You're asking him whether
whether
it hurts, whether he can feel it.
That's like the thing. So I'm checking for pain, stability, and the feeling, because he can only
response.
Yeah. So he was full time awake, so it was easy to check, but without consciousness, yes, it's quite hard to check for any spinal trauma, because you wouldn't see a movement, of course.
But then you're just getting into putting him into the recovery position.
Yeah, but I'm checking as well before, so because if I'm checking for any fractures, that's like the thing before you put him into a recovery position. Yeah, we waited till EMS and Tally arrived. He got an IV line, a little bit of, I think it was as well, fentanyl. They used pelvis immobilizer as well to stabilize it, just in case. So there was no actual sign of a pelvis trauma, but they used it. And they used a stiff neck as well, without any obvious damage of the neck. Yeah, ends up in a, what was it, L1?
4 or 5?
L
T3, 4, 5.
Yeah, any fracture of the lower spine and
Scap.
Was it scapular fracture? Yeah. So this was not a thing during my check, so he didn't have. So the thing is, when you have a strong pain anywhere, it's quite hard to figure out that you have another fracture or another pain in your body. So, for example, when you have teeth pain, you can use your nail and put it on the side of your thumb to relieve a higher pain, and this will reduce your pain in your teeth. That's a nice thing to do as a first thing. That is a good example to show if you have a stronger pain anywhere else, it's hard to figure out the other part. So he didn't feel it. Is anyone in touch with him and has updates on his recovery?
No. Do you know Simon? If Corey's alright? What's the story?
No, I spoke to him a couple of days after the accident. I haven't heard since.
But he just texted me the same day already that he is on better side than expected. So their doctors said on this same day that they are not expecting any long-term spinal injuries, which is quite good.
Was this with a back protector or no back protector?
No, it was speedwing with harness.
No protection.
Nothing.
You don't need them with speed rings.
They go faster, aren't they? So they're
Faster and safer.
Just
I mean, that was part of the reason why they treated it as full spinal and full pelvic, because they saw there was no back protection in the harness as well, because there was literally nothing.
Second accident happened on last Monday. I was on the ground and witnessed, we have to talk about that later, about a witness report, how one of the students was suddenly in a flat spin going down on the right hand side in front of the launch, and I would say about 5 meters above the ground, the last 5 meters were a sudden drop, so the wing totally collapsed and he crashed. Student was quite lucky. There are a couple of stones right around his crash site. Teacher approached student at first, let us know straightforward. There is an ambulance. That we need an ambulance. Then I arrived as well. Experienced a patient in a painful situation. There is a scale called Glasgow Coma scale in EMS, which is used to do FPU in a little more detailed version. And this was, say he was awake, but the orientation of time and situation and location was a little bit reduced, so it was hard for him to tell us that he was paragliding and dropped, so he didn't know what actually happened, just that he has pain. It was quite hard to turn him or to keep him on the back because there's a steep slope already. He had a full foam protector, so even this was quite hard, but it was not really easy to remove the harness in this position, so it was a steep slope. He was in pain, so we decided to keep the harness on. He had a dislocated wrist on the left side without any painkillers. So without a painkiller, it's possible to inline it, but I wouldn't do it. But in case of a backcountry situation, it's important, actually, in my opinion, it's important to try it even if without any medical experience, because the damage that results in a dislocated joint is quite high, so nerve damage and vessel damage. But this happened at Taylor, so I can expect that EMS will be around after 30 minutes. Surprisingly, they didn't inline it. I don't know how the standard is for St. John, but if I would be at the EMT, I would come up with the idea to inline it.
Is it easy to inline it?
Those joints, yes.
Okay. Is there a risk?
How do you go about it?
Keep it stable and pull in line of the arm. The thing is, for example, when you have a dislocated shoulder, the shoulder on its own is not a real joint. So there's just like a muscle stabilizing everything and a small bone plate to keep the humerus on place. And the muscles are already quite strong, so you need to pull quite hard. And in case of a fracture, you won't be able to see if it's a fracture or a dislocation.
Is there a risk of doing it wrong?
You can track nerves and vessels, can't you?
Yeah, that's the problem. But with ankle and wrist, I would always go for it because the bones are in a better position. The kind of fracture we could expect, they don't bring the high risk, for example, shoulder or hip fractures. Pull on them and try to relocate it when you're in a backcountry situation.
You always leave shoulders out, you don't try to put somebody's
You don't
shoulders
try
back
it.
out of your hands.
But wrist and ankle is important. Otherwise, you have the high risk of, as you said, a trapped nerve or a trapped blood system.
Do shoulders?
I put my own shoulder back on the side of the kayak and I pinch one of the nerves in the back of my hand still numb. So you can just pinch it. But I put mine back and I didn't know at the time. But I've just always been told since then you just don't pop your own back in, you just don't touch your shoulder. But I found it out after the fact.
You mean you don't do your own?
Well, you just don't try in general because you can push it in. If you push it in the wrong way, you can push past the joint or behind the joint or to the side of the joint, and it'll be like it'll pull it through and just cause more damage than it will do good.
So, example of my daily anesthesia nurse life. When there was a patient in the emergency room with a dislocated shoulder, they always checked the shoulder after inlining it again, because you can't be 100% sure. You can check it, but just by feeling. A high experienced doctor could do this maybe, but you're never 100% sure, so they are checking it with the X-ray. Yeah.
Twice, not fun.
So I don't have any update of this student because I don't have any number. So with that, I only figured out that he has a dislocated wrist, no other injuries, probably just an impact trauma, but no.
Broken ribs and ruptured spleen expected to be out of ICU today.
Wow.
Broken wrist, dislocated, broken ribs, ruptured spleen, and expected to be out of ICU today.
Okay, that's an update. Good. Yeah, spleen is quite a big thing as well. So this organ,
it's all blood, isn't it? Pretty much.
It's a blood organ. Yeah, so it's if it's bleeding, it will. So the skin of this organ is strong enough to keep it compressed, but after a while we call it second rupture. The skin ruptures as well, and then you have a mess. Everything is going through. Yeah. Sometimes it's necessary to remove the spleen. Yeah. Good. Any questions?
Yes.
Yeah.
Did the harness and the foam protect the student?
So if
did it provide any protection? Or could it have been worse?
Yeah. So from the altitude he dropped with the speed without a foam protector, I would say there would be more damage, definitely. Because I expected already more damage when I approached the patient or the pilot.
Body.
That AVPU that you were talking about, what was that again?
Awake, verbal responding, pain, and unconscious. So we're checking the conscious situation of the pilot.
And you said all of that was like sort of under the R from doctors, as you see.
Yeah, that's under the R. So dangerous. So before we do anything with the patient, check if it's safe for you to approach the patient, send help, check the response of the patient, and then check for the vitals A, B, and C. And in case of no breathing, unfortunately. CPR, yeah.
Sebastian, if you come across a pilot with massive external bleeding before you've even checked the airway or breathing, would you treat that first?
So if there is an external bleeding, stop the external bleeding first. So EMS is using the X, A, B, C, D, E, and X is external bleeding, exsanguination, whatever, different meanings. So stop the bleeding before, yeah.
So how long is it before a patient can bleed out? So like 4 minutes or something?
Kind of, yeah, depending on the size of the trauma. But because when you're cutting your finger quite deep to an artery, the amount of blood that is capable to go through this point is definitely less. But when you have a half cut off arm, for example, or other limb, there's a lot more blood going through the second, and one heartbeat pumps about 60 milliliters in a normal situation, kind of.
So yeah, the story is you treat that circulation before you even check the airway before breathing, because otherwise.
Yeah, so this is public first aid.
Yeah.
Yeah, stop the bleeding.
In terms of the bleeding time, they'll die of not having breath faster, but
Yes.
it's much easier to put air into someone than it is to stop bleeding.
Count the blood back.
So you can breathe for someone instantly by giving them CPR, but you can't put blood back into them.
Yeah, yeah.
So you've got to focus on stopping that massive hemorrhage first for that reason.
That's what I thought. I was just giving
Yeah,
confirmation.
Sorry, I missed that point, yeah. But good that you mentioned that as well, yeah.
Would it be relatively unusual in a paragliding accident though to have a large amount of external bleeding, or like it would be internal bleeding?
So my experience is 2 out of 2 without an external bleeding, but that's not the science. A friend of mine had an accident a couple of years ago as well, paragliding, and she dropped as well 10 meters without any external bleeding.
Mm-hmm.
So you need violence from outside, a force that is.
Well, you fly into a tree or a wire or fence.
It's skewered.
Yeah.
Yep.
It's cutting through your skin. So just an impact,
Could be your
hitting
knee.
the ground wouldn't be enough.
Could be your knee going through your leg.
Yeah, compound your femur. When it takes out the artery as well, that would be a quick way to start bleeding a lot.
Yeah, but
I haven't read any accident reports where there's been massive external bleeding. I don't think.
I don't know the facts for worldwide accidents, but
I think it's pretty rare.
yeah,
It's
that's already a good point, isn't it?
That's one good point.
I had a comment and a question regarding Corey's accident.
Yeah.
The comment is that I was there on that site and it was great that you had a radio. So just a reminder to have a radio, because Bevan and I were down the bottom and we were able to let Sebastian know that he could come down. It was super helpful, and also trying to manage the other pilots around. People were still flying that didn't have radios, which was quite stressful when we knew there was emergency services coming and we didn't want people coming in and landing. So having radios when you're flying it's not mandatory, but it is super helpful.
Should be mandatory.
And the question was, we did the first response on Corey and I saw him drop, and I, looking at him, didn't think there would be much risk of him bleeding. But we still did the sweep of blood, and I was pretty uncomfortable doing that because I knew he had a spinal because he was complaining about back pain. Would you have bothered doing that hand sweep to check for blood, or if you didn't suspect there was going to be any bleeding, would you have left it?
What if you landed on a stick?
It's true.
That's in his back now.
And at the same time that you would have been doing that, Sebastian, I guess you would have been checking for pain around his lungs.
Yeah.
So you're doing
So-
it at once.
The thing is,
What are you walking sickness?
Problem too is how wrapped up are people, because you imagine a cross-country flight, people landing, they've got lots of clothes on. Use a lot of litres of blood can be hiding away in that clothing that you don't know about if you don't check.
yeah. So
And,
That-
and again, people will have an injury and they'll focus on one bit of the pain and not necessarily something else.
So removing jackets and trousers, for example, especially during winter time, brings the next problem: keeping the patient warm, right? So if you're removing anything, you should be able to protect them from hypothermia on the next step as well. It's like riding on an edge, right? To make it perfect. There's no standard thing. That's the thing what I wanted to say. There's no standard protocol you can follow up, depending on the situation.
Maybe I got the question a little bit. Maybe I heard it a little bit differently, because it sounded like you were asking about doing this sweep, even though you clearly causing him discomfort.
Yeah.
Is that where you were going?
And risking moving his spine, yeah.
Well, I mean, you answered yourself before when you said it's much harder to put blood back into someone. If he's going to die there on the spot because he bled out because he didn't check,
Yeah.
or, you know, is there a chance of him having a spinal injury? Like he's clearly going to be hopefully mostly fine, right? But he could have still get down.
So if you
something happening instead.
if you're more than two, so I would recommend at least 3 persons. Then you can turn them on the side to check the back as well. So one person is immobilizing the head, and the other 2 are turning him in line. If you want to check the back for bleeding, then you can do this as well. But don't do it on your own, because the risk of twisting the spine is too high.
James is going to walk it off.
Good. Yes.
Not a question, but a thing that I remembered when I was doing PE2. I wasn't at any of these incidents, but in the situation when not every pilot was landing when we were expecting a heli come in, we learned about like putting our wings in a cross shape to signify that people should land.
Okay.
I'm not sure if that's in anyone's mind or if we forgot, or if that's
That is a thing, as long as you're organized enough to have the people around to do that. There's also a use the horn in a car in short blasts 3 times and repeat that. Never heard that at failures during an accident, even though we're trying to get people to land.
That's a good idea.
You can add that to the website.
Yeah.
I actually got
But it's
called-
there.
I can make it more prominent on the website.
I didn't have a radio. I'm a guilty party here, just because I haven't bought one yet. But I got called in the air, and I picked up my phone in the air because somebody was calling me. And I was like, oh yeah, what's up? Is everything okay? And then I got told, oh, quickly get everybody out of the air. And I was one of, I think, 3 pilots or something. And just screamed at everybody because everybody was far enough away from the hill that we can hear over the wind. Even when you're in that, you know, if you're 20 metres away from the hill, even that wind's still loud enough that people can't hear. And I don't know who was on the other wing that day. It was the last guy of the air. But they just didn't hear us for another minute or 2, you know, and it was just impossible to communicate. So it's definitely encouraged me to get that. It made me really see the relevance of that, because that could delay a helicopter landing and delay somebody's, you know, trip to hospital by a minute or 2 or 3 or 5, whatever it is.
Do they use a standard approach in or do they just fly straight to the accident site? Because
no, so our helicopters are approaching and like a first assessment as well. So they're checking the scene, what dangers are possible. So as we are doing, so is there any stock running around? For example, horse accidents. Is there any free horse running around as well? Power lines, they're checking for them as well, and they're landing unexpectedly into wind. Helicopters.
So they're not going to come in a standard way. I mean, I've flown with helicopters a number of times, and
They will probably also
where
go
you
past
can be
you a
if
few
you
times.
fall out of the
Yeah.
sky. But it'd be nice if they, if you happen to be in the air and you see a chopper coming in that's obviously going to an accident, you expecting that they're going to fly any particular approach.
They don't necessarily know because they fly to so many sites. We just don't, if you're flying a chopper, it's like flying a paragliding. You don't know that site the first time you go there, do you? You've got to follow the local pilot around, understand what's going on. They have to basically approach from recommended altitude based on that flight zone.
They would communicate as though they'd be expecting that there could be other aircraft.
Depending on the pilot that's there on the day, depending on who it is, they don't necessarily have exact standard approaches for each site that's written down in the textbook. They just have general guidelines that they follow like we do, They don't know the exact ins and outs of how that air's moving over the ridge and what we all know about that site. We know way more than the helicopter pilot's going to know about how that air's moving. So they still have to approach it differently each time, depending on the strength of the wind.
They'll not think about you as someone flying on something that can collapse.
Yeah.
They will not think about the wake that they leave behind when they do approach.
Yeah.
They will think about the bubble of air that they disrupt that's under them, the pillow that may put them on the ground, but they will not think about the 10 minutes of the wake turbulence behind the rotor when they fly through a narrow valley and then you're stuck in it. Well, we're way better off being on the ground before they get there.
Yeah, the wind really doesn't load in too much. I think those BK117s can just about fly in a hurricane.
They fly until they don't.
Yeah.
And they just drop.
So, probably turbulence is not something that's big on their minds. at the wind speeds we're flying in anyway.
Good. From my side, I'm done for today.
Thanks very much, Seb. That was a great talk and a great run through kind of basic what should you do. Really appreciate you spending the time and thank you all for coming. I feel much encouraged. I actually wasn't sure there'd be many people at all, but I'm really keen. I'm really glad there's keen people because we're obviously getting...
Yeah, I think Corey and Matt as well.
Yeah, we are getting a lot of accidents. We've certainly got a value out of the bloody donation to Westpac Rescue this year. Yeah. So thanks again.
Just for a show of hands, please. About 2 years ago, I've organised a visit to Garden City Aviation, which is the operations that run the Westpac helis here. And we went to see their hangar and the helis, and we talked to the pilots, and we talked to the paramedics there, and so on. Give you a show of hands if there is interest if I organize it again. So no then. Yeah, I'll talk to Scott and try to get it on maybe November.
We're going to have a talk on the 14th. Anton's going to talk on November.
Okay. So I'll do it on the 14th.
Yeah, maybe a couple of weeks after that, in December. And I think Mara's going to do the Christmas party again sometime a week or two before Christmas.
I'll do it on the weekend.
Oh, one point on that, so we had a really interesting experience over in Europe recently. There were some wildfires and there were helicopters working on the wildfires, and one of the helicopters basically paid a visit to launch. It was a fucking big, I don't know, helicopters. It was a big fucking helicopter. And he basically popped up behind launch over the ridge on the leeward side, made it fucking obvious he was there, and then left. There was no rotor, there was no turbulence off that at all. Like, there were wings spread out and launched and they didn't even move. So he knew exactly what he was doing, and he made it really obvious that he was there. The other thing I wanted to point out from this is the crash that ended up, my crash, that ended up with us going to Garden City Helicopters. They showed the video because they record the rescue for their own kind of training purposes. And I packed all my gear up. It was me and Jacob on the side of the hill on screen. We were completely invisible. I even had a torch on trying to point it at the helicopter. They couldn't see us at all. So if you are in an incident, one of the biggest, most obvious things we've got available is our wings. So a wing or reserve or something, put something out that the helicopter can see. Put it away before they get really close, but make sure that they've seen you, because a person, you're invisible. You can't see it. Totally invisible. And this is on like just a nice open scree slope. We thought we'd be pretty visible, but no. So yeah, use your wing.
I think they actually landed away before they came down to you, didn't they? So
They landed in Klondike and asked where he landed.
They were hunting around for like 10 or 15 minutes trying to find us.
James?
No. Someone rang from the pub to say there'd been an incident. We were busy walking off the hill trying to work out how to get down. So we didn't intend to call for a rescue.
Something I could probably add just on the PLB note too, guys, is if you're ever at the bottom of a valley using a PLB, especially in our backcountry in New Zealand, if you haven't had help, and I can't remember the exact rule that we were taught when I was doing the license, but if you haven't had help in an hour, you could be in a dead zone, a radio dead zone. You want to move that PLB if you've got an able-bodied member in the party and still have a signalling, like a wing or a fire. You want to move that PLB by 100 metres, just in case you're in a radio dead zone. I think it's 2 hours, move 100. And if it's another 2 hours with nothing, move another 100, but have a secondary signal where you actually are. So fire, wings, high vis, whatever it is, because you can be in a couple of the guys that the old boys who taught us to fly the choppers, they'd had the earlier versions of PLBs and they weren't as accurate as they are nowadays, but there's still a chance that you might not be sending out an accurate radio signal. And they could be over the next valley over just because it can bounce over a hill and down and not go to a satellite. And satellites come over a valley and then they drop. So they might think you're on the opposite side or down the opposite end if you're in a bowl. So I think it's 2 hours. I can't remember the rule on that. You have to look that one up. I think move it if you haven't had help in a couple of hours.
We were also told that by the Westpac themselves that if you can't get to your person right away, for example, they're upwind of you or they're on the next ridge or whatever, better than triggering your PLB or inReach while you're in the air and trying to make progress towards them. You're better off landing safely somewhere and then communicating roughly where your mate has gone down.
Before going down into the valley?
Well, whatever it is, like when you trigger your PLB, don't be moving.
Yeah.
Don't do it in the air.
Once you trigger it, don't move.
Is that true for PLBs and inReach?
Same. So the satellite goes over the top, kind of goes, oh, there's a thing.
Yep.
Next time it goes over, it'll go, oh, the thing's still there, and it'll be a bit more accurate. If you're moving, they don't know where to look. They'll have these massive search radiuses from each.
And on a paraglider, you know, if you trigger your PLB in 8,000 feet by the time you get on a glide, like there's no way you're going to land in the same spot.
No.
That's right.
That's where it hangs, yeah, you can be miles away.
Yeah, it's only going to be that you don't get help within a certain time frame that you ever move the PLB. I can't remember that time frame though, so don't take that as gospel. But if it's been a certain number of hours, I think you're supposed to just move it around the site by 100 metres or across the site one direction. And I don't remember the rule on that, but it might pay to look that one up because it killed a couple of guys. They were found with their PLBs 2 days later, ran out of battery, dead.
Got a question, but is GPS 3-axis as in X, Y, and Z? So if they see something and it doesn't fit, it's like, what's
Depending on the amount of satellites you got. You have to have 12 satellites or something, or some certain number at any one time to have Z. X and Y is only like 4, but to have an accurate Z, you have to have, above 8 or whatever. I don't know the number again for that, but you have to have above a certain number of satellites to coordinate X, Y, and Z. Because it can only see if it's got, if you've got an X and a Y satellite, you can't calculate the Z necessarily accurately unless you've got one over the top. So there's a certain number that you need.
Well, it's also, even if they get you in the high altitude, and that's the last point, then the surge, the cone of the surge is huge. That's like, go back to, where was it, Owens, when Kiwi had this accident, and his last bend was, what, 16,000 feet?
Did he trigger when he was in the air?
Well, he was tracking, right? Inreach, the advantage of Inreach is tracking as you go, and then suddenly it just stopped from memory.
Yeah,
it
wasn't functional when he after the crash. It was.
So the interval is 10 minutes, and no one knows what happened within 10 minutes. Yeah. Well, they can't figure it out.
Oh yeah, and on that note, with the change of inReach, I know you might choose to pay for your pings. Don't change the setting more than 10 minutes. 10 minutes is already a long way.
Yeah, that's a long time.
Yeah.
Cool.
Right. Very good. Thank you. Thank you, everyone.
Thanks, everyone. I enrich, Nathan, enrich.